Good morning. My name is Anita Day. I'm chair of Eastern North Herts NHS Trust. My pronouns are she, her. And today is the 11th of September, our meeting of the Trust Board in public. I'd particularly like to welcome board members and guests, but a particular welcome to some particular guests who are here to talk to us about a patient story, and I'll introduce them formally in just a moment. I'd also like to welcome some new members of our board who are here this morning. We have Diana Skeet, who's joined us as a non-executive director. We have Janet Scotcher, who has joined us as a non-executive director as well. And we have Zoe Aslanpour, who's here as an observer this morning. But we'll talk a little bit more about some of those changes in a bit. Just going through, to kick off our agenda, declarations of interest. I've not been notified of any specifically to today's agenda. Does anyone have anything to declare? No. Obviously, our standard declarations are on the website. In terms of apologies for absence, we have two apologies that I'm aware of. Karen McConnell, our Deputy Chair, and Richard Oostrom, who's actually another of our non-executive directors, is also not able to make it today. Moving then swiftly on to one of the most important parts of today's agenda, I'd like to move us into a patient story. As you will know, it's our tradition that at the beginning of each board, we like to hear from either a group of staff or a patient or group of patients, because it's really important that we remain and are always mindful of who it is we provide these services for and the people that help us to deliver those services. I'm delighted to welcome today Dawn, who is going to come and talk to us about her experience with her son, and supporting her, Eleanor and Grace, and indeed Lizzie, I think, as well, from our team. Teresa, are you going to kick this off, or how do you want to do it?
An absolute pleasure, Chair. That would be a pleasure, Chair. Thank you. Dawn, we've just briefly met, but I feel so honoured that you're here to tell what is a very raw story about your son, and I think you're flanked by two of our very, very senior Royal Dahl nurses, Grace and Eleanor, who have a responsibility for children with life-limiting conditions, and I'm really excited to talk through at the end of your story some of the initiatives we're taking forward, some of the learning through Charlie's, telling Charlie's story to us. So thank you, Chair. Hello everyone, I'm Dawn, I'm Charlie's mum. Charlie's 17 now. He was born with a mitochondrial life-limiting condition, didn't really kick in until he was 3, whereas before he'd be babbling, moving, you know, normal boy. And then at 3, it all kicked in, proper seizures and inability to be able to move or speak. However, his will and tenacity's there, and he's still here. He's 17. He's strong, although with conditions they come with seizures, with him recurrent chest infections, all things that are recoverable, all things you be treated. We have had numerous admittances into hospital. We meet these lovely people on quite a regular basis, but we have for years. Come to December, he came down with COVID. I did too. I was poorly. He obviously goes to Charlie. He's absolutely, you know, it floored him. So he did struggle. He struggled on Optiflow. He's on the children's A&E. I think initially they agreed to take him into ITU if he needed it. Adam Brooks, there's a cut-off at 16 for PICU, so he doesn't qualify for Adam Brooks. We're falling a little bit between the cracks of adult and paediatrics. But when it came to it, when he was still struggling a little bit on the Optiflow, maximum pressures, adult ITU wouldn't take him. He was declined. Thankfully, he recovered on the children's ward. A few weeks later, we're back home, and Christmas Day, would you believe it, he was back home on that day, and he's been fine ever since. his condition, yes, it defines him, but he has recoverable illnesses that up to now, fingers crossed, he responds each and every time. Antibiotics, maybe breathing support, epileptic rescue medications. Yeah, he throws it in, but he recovers. He should be given the chance that if he requires a bit further, and I'm not saying ventilation or resuscitation, when he gets to those degrees, that's a different conversation. But he shouldn't be declined just based on his prognosis, because he's battled through. Each day, he proves everybody wrong from when he was diagnosed at age 3. Said he wouldn't be here at the end of that year. He's 17. And he's not on oxygen at home. He's a pickle with seizures and other stuff. My 15-year-old, who's healthy, she's a pickle. You know, this is our life. This is how we live. It's just different to others. But he should be given a chance. When he was, Eleanor will dictate, had a conversation with the ITU team, and they have agreed to, they've put a condition basically, was put to us that they would accept him into adult ITU if he required it, but it was on a condition that they wouldn't do anything invasive. Who wants a condition put on your child when you come into hospital that you know you're coming in on a conditional basis? Surely you should deal with what they're coming in with at that time. Is it a chest infection? Is it seizures because he's in pain? Surely you dictate first what it is that they're ill from and see what treatment can be given and see if they can respond. Don't put a condition on them. They should be applauded for getting to this age. Yeah, we go from children's services of being nurtured and everybody doing everything they can. We hit adult and you've closed the door on him before you've even met him. ITU haven't met him. The adult team, we've only just met the respiratory consultant for adults, which is great, and the respiratory nurses. We haven't met the team yet. They haven't met him. And he is a person. And he deserves this cohort coming through. They need to know these kids. They need to know they've come all this way through their life and they're still here. If they're lucky enough, they're still here, should be given a chance. That's about it, I think.
I don't know, Ellen and Grace, do you want to add anything?
I think, obviously it is an absolute privilege, and we really rely on families like Dawn and Paul and Charlie and Eve telling us the reality of what it's like, because you'll probably know we had quite a lot of meetings around December and January that Grace and I held, trying to get the right teams together, and ITU and the hospice, and sort of hoped we'd got the right plan in place for Charlie. But it's actually the honesty of Dawn and Paul for telling us later, actually going home, how that then made them feel. And I know we've got a lot of learning to do about how we have these conversations, how we prepare parents, children, young people for the changes with the Mental Capacity Act, parental responsibility, and looking at our transition pathways. So yeah, here to learn, and with gratitude for you working with us so openly. Thank you.
So we're happy to work. We want to be collaborative. We know the Mental Capacity Act. As a parent, we haven't got the rights as we did before he was 16. But we want to work with you. We've got the knowledge. The nurses who have looked after him for years have the knowledge on Charlie. Non-verbal doesn't mean people can't understand him. You just got to know him. And that comes from knowledge. And we're happy to work with us. Let us work with you. We're not combative. We want the best for everybody, and to make life easier for everybody, work together.
Yeah. I mean, thank you so much. And can I say, first of all, thank you for sharing your story so eloquently. This is as parents ourselves, most of us can actually, we can't imagine what it must have been like being in that situation. And thank you so much for sharing it. But also, thank you for, at this point, saying, help us to do better and help us to, really grateful for that. I'd like to open it up for questions. Justin.
My name is Justin Daniels. I'm the medical director at the Trust, and I'm a paediatrician by background. So thank you so much for talking about Charlie Thank you for talking with such passion, and thank you for really challenging our thinking. I think this is an area that's changing, and it's changing quite rapidly. Throughout my career as a paediatrician, I've been privileged to look after a number of children with chronic, life-limiting conditions. And things have really changed in paediatrics, and they've changed especially on PICU. What we've seen over the last few years is that actually now the majority of children being admitted to PICU have a life-limiting condition. And that's very different to where it was a few years ago. I think the problem is that adult ITU hasn't yet learnt that. And as this group of young people come through, we're going to have to change the way that we do things on adult ITU as well. I'm up for that challenge, and it'll be through stories like yours that we move the thinking on adult ITU around that. I think there is another problem going forward that we should be thinking about as a board, which is how we take the care of children like Charlie forward from a medical perspective. Because you're right, paediatricians are generalists, and they will be used to looking after all the different facets of the care of a young person with complex needs. And there isn't really an equivalent in adult medicine. And I think one of the challenges to us as an organisation is how we think about holistically looking after children and young people as they go through into adulthood. Because it's not a service we've had before, it's not a service we've needed before, but it's something I've been thinking about since I read your story, because I think we need to put together a package of care, somebody who has overall responsibility. The default has always been the GP. I think that's difficult with really, really complex needs.
Yeah.
And I think Charlie and his cohort of children as they come through the system will mean that the system needs to think differently and act differently. But thank you so much for talking. It's incredibly valuable to hear your voice and to hear all that you've been through. And Eleanor and Grace, thank you for being here.
Thank you, Justin. David.
Thank you. Thank you. I'm David. I'm a retired GP and non-executive. I've worked in the NHS all my life, and I think one of the issues that your story raised in my mind as a GP is how we, patients, people, get access to services is often around a label, an age, a defined condition, a defined problem, and actually people are much more complex than that, particularly with long-term conditions. So I agree with Justin. I just want to add that I think you've helped me focus on a wide issue about how we enable people, patients, to get access to services and don't always think of them as a particular disease or illness or condition.
Heather.
Thank you. I'm Adam, the Trust Chief Exec. Again, I want to add my thanks to you to Sharon, because it's really important for us to be challenged in this way. I just think corporately to the board there's a couple of reflections. So one is, many people around this table have got children who have gone through this kind of transition, and some have got children with some quite challenging needs. But I think what you highlight is an example of this principle of transition from children's services, whether it's in mental health services and physical health, is a real risk for us. We've got one of our 4 trust priorities we call seamless services, and we'll often talk from a patient perspective around when you move from hospital services to your GP to community services, whereas actually every day we've got challenges within the organisation, and this has highlighted it completely between someone who's well known and embedded within one service needs a different one, and that shift isn't seamless, as Charlie's story has highlighted. So it kind of gives us the prompt that we've got to keep focusing on the internal seamless services and not just the external ones. But I think the other point for me that's really tied in with our priorities is when we've set 3 values for the organisation, and one of them is respect. And I think you've highlighted the fact that in all that we do, whether it's clinical or as board members, etc., there's a real risk that we think we know best because we're experts in the field and our doctors have been doctors for years and years. But it's respecting the view of the people who know the patient best, which is often the carers, if not the parents themselves. And the final comment I'd make, it really chimes with another story that we've heard here, and Ella's been very involved in, with Sarah Lee and her son Nate coming through our services, and just that sense of, and one of the things that really strikes me is that when we were talking about the passport, etc., paediatric services, children's services were kind of increasingly well known to that, but if suddenly you need to go to X-ray or another service that we don't have a dedicated paediatric team, some of that can fall down. So I think there's a number of bits we need to take away from this story when children go beyond the knowledge base that we may have established, and you've clearly built a relationship with some of the core team here, but they won't be there all the time. So thank you for giving us a lot to think about.
Thank you. Teresa.
First of all, Dawn, I noticed you've brought a wee picture of Charlie, and I think you wanted to make sure his voice was in the room. So if you wanted to share that, we'd love to see it. And secondly, Dawn, we have a weekly critical care improvement committee, and I chair that. And Charlie's story is the first agenda item on Monday. And I've spoken to Sunil Grover, who's our head of intensive care, and he has really reflected with his team on how we get that criteria for admission right, how we are human, and how we work together collaboratively. So there's no doubt that we didn't get it entirely right in Charlie's event. We need to get it right for Charlie in the future. We need to get it right for every child like Charlie. And I'm not going to pretend that we've got all the work done, because we haven't. I think at a local level in our trust, we are committed to getting this right. And we've got Amanda here, our divisional director. We've been working behind the scenes to see how do we start to get Charlie's voice in that critical care environment. So please, I'll take up your offer of working with you. That's an absolute privilege. And then secondly, I think there is, as Dr. Daniels was saying, a bigger systems piece of work. We need a board that sits across all of the acutes in the integrated care that looks at just children, whether it's the under fives or the over fives, whether it's an acute illness or a chronic condition. And Mary Emson and Natalie Hammond, who are the senior nurses in our ICB, that's our sort of layer above us, have agreed that we need to do that, and that needs to happen this year. So I think your diary is going to get absolutely jam-packed on with requests to come and work with us, but I just wanted to say you are completely, and Charlie is on our minds, and most importantly on our agenda to change for the better.
Thank you, Teresa. Kevin.
Hi, my name is Kevin Howell. I'm the Director of Estates. I probably don't understand the clinical sides of this as much as my colleagues do around it, but I was just looking at this and reading through it, the identification that Charlie needed CPAP, and we're looking at Bluebell at the moment, and I'm wondering whether or not, whilst the discussions are on around the difference between 16 and 19, whether or not there's something that could be a higher intensity support in Bluebell, or as we do the work there for CPAP, to actually ensure that we've got a facility. I'm not saying that we could have an ITU or a paediatric ITU in Bluebell, but it seemed like Charlie needed here support that could have been physically been achieved, as long as the support clinical teams were there to oversee it. And I just wonder, when we look at, for the interim, while we're working around the, for 16 to 19, the Addenbrooks, whether or not when we look at what we're doing with Bluebell, whether or not we should look at a higher acuity section within there, serviced well by oxygens, and to allow CPAP and stuff to be done. Just a thought, and perhaps clinically there's a reason why not. I'm sure they need higher acuity support.
Thanks for the suggestion, Kevin. Peter.
Like others, very touched by the story, and I was so reassured of what Teresa's had to say. The comment I wanted to make, however, was how positive it is that you have such a great relationship with Grace and Eleanor. And that's so good, because it's an example of a part of the service that's working really well, and I'm pleased that you touched on that.
Thank you. Any more questions or comments? I had one question, actually, and I don't know whether it's come out. I don't think it's come out elsewhere. The bit that I think really got to me about your story was where you talked about the fact that when the conditions were put in, and actually they would only accept Charlie if there was a do not resuscitate order in there. That must have been incredibly traumatic for you to hear that. I mean, I can't imagine that. how well did we support you? Because it may or may not have been appropriate in Charlie's case, and sounds like it wasn't appropriate. But there will be occasions when those conversations do need to happen. How well did you feel supported by us, and what do we need to learn? Because when those awful situations do happen, those conversations need to happen.
Absolutely. We were blindsided going into the meeting that we went to in January. Not going to lie, we went there to discuss the conversations that Eleanor and the ITU team had discussed. So we weren't expecting to be told we've got a condition. And to be honest, hearing that they'll accept you in, but you're on a conditional, is soul destroying. Absolutely soul destroying. Because when you have to hear words, believe me, we've had, as you can imagine, we've had experiences where we've been in and out of PICU, and we've had conversations of what if this happens, be prepared for this and that. We're not immune. We might hear it a few times, and we have over the years. You know, thankfully, we dip around. We're not immune to it. It breaks your heart, because it was as if it's as if we've brought him up to get to 17, 18, we're transitioning, and then we've hit this point, we're hitting adult. Oh no, sorry, we won't do that. No, wouldn't do that, close the door, without even trying anything. It's like, what's the point in doing everything we have done to get to this point with everybody working together and health and the teams, us, everything we do as a family, we make it work. We don't begrudge, we made sacrifices, we work with it, we live it. This is our life. To have that decision done before they've even met him was just, what's the point? What have we been doing for you to then make that decision? And then for us, if we need to come back in, well, it fills with fear. What are we facing when we come in now? What decision are you making for us without us even having a conversation? So, long story, but it felt like not very good, without swearing. So.
No, I mean, Eleanor and Grace, I mean, what's your experience of those, of because it's an appalling time in any family's life. How well do we do it? Could we be doing things better to support parents and families at that
I'm sure we can always
point?
do things better. Always. I mean, we for Charlie, for example, he had an advanced care plan. We'd had these conversations. As Dawn said, he'd been in and out of PICU. Dawn and Paul are realistic. They know at some point, they might be having to talk about do not resuscitate. But I think it was always felt like that would be a decision made with the team at the time and an honest conversation. And there's a lot of trust needed, isn't there, in the team at the time. I think we can always do better. I think there's always learning. I think we try to have these conversations early in time, but yeah, every family, there's always something to learn. We can improve for sure.
Just one thing more. Words are powerful. Words are extremely powerful, and the impact that those have, as I say, we're not immune, we're also not naive. Believe me, we live this, we're not, we have seizure, you name it, we are a mini ward at home, and we do that gratefully, thankfully we do. But your words have a lot of power that can take the wind from out of your sails, that actually we should be supported more as a whole. Can't say you can do that for everybody every time. We're not, but so we are realistic. We want to have conversations but there is a support, and there is got to be known that there's an effect to words and actions, that it has an impact down. It just needs to be recognised. I don't know how to manage it completely at all, but it just has to be acknowledged that there is an effect, an impact.
And I think, sorry to add in, I think it's about the clinical team finding out afterwards, have the parent family understood what was intended, what comes out in the letter afterwards, the wording used, might make sense to the clinical team, but actually for a parent reading it, are they getting the same message from that as was intended?
Yeah, I think that was where I was sort of heading, was there something about our communication at the time. But I think if I don't see any more questions or comments around the room, let me just reiterate, I mean, thank you so much, Dawn, for coming. Yeah, we do appreciate this was a hard story to tell, and it's a very hard story for us to hear, because we do try and do our best, and at times we don't do things as well as we should, and we need to learn to get better. But actually from hearing from you and patients like you is absolutely how we do that. And I think what's really heartening is the fact that you want to help us do that. We're really, really grateful for. So thank you for your time today. Thank you for Grace, Eleanor, Lizzie. Thank you for bringing the story to us. This was an important story. And as Justin and Teresa have talked about, we'll be taking some actions to try and make sure that others don't have the same experience. Thank you.
Thank you.
Right. Thank you for that. A very sobering story indeed. Let's now move on to our agenda. The next item is our minutes from our last board meeting on the 10th of July. I wonder if we could just confirm to me that you are comfortable that that's a true and fair record of that meeting. Are we happy that that's a fair reflection? Thank you very much. Moving on then to the action log. We only have, I think, one item on there. Yes, from the maternity assurance report, and I believe that's coming up. It's been to QSC and it's part of the report later on, so I think that's fine. Thank you very much for that. Let's move on then to questions from the public. Stuart, do we have anything?
So just to confirm that we haven't received any questions from the public.
Thank you very much. So then let's move then to the Chair's report, which is a verbal one from me. I mentioned this at the beginning, but we have had some changes, or are having some changes in the coming days, weeks and months. So first of all, to welcome our three new members of the board on the non-executive side. I've already welcomed formally Diana Skeet and Janet Scotcher. We have another non-executive who is not with us today, Richard Oostrom, who will also be joining our board. And I've also, and I mentioned this at the beginning, and we also have currently as an observer, Zoe Aslanpour, who is an observer at the moment because she will be the Dean of the new medical school at the University of Hertfordshire, and subject to hopefully us getting teaching hospital status and a few other changes, she will be joining us as a permanent member of our board going forward. So that hasn't happened yet, but at the moment just an observer, but we look forward to doing that very soon. The other change, of course, is that we have to say goodbye to a member of our board, and that is Dr. Peter Carter, who will be stepping down at the end of next week. I think it's next week. He's been on our board for many years. He's been a really important advocate for our staff and patients. Has made a really big contribution to our trust and our board, and we wish him all the best for the future. But and we'll be sorry to see him go, but wish him all the very best.
And it's been a pleasure working with you all, and I will follow the fortunes of the Trust with great interest, which I do feel sure is going to go from strength to strength.
Thank you, Peter. Right, that's all from me, I think, so I'll hand over to Adam.
Thank you very much. And just before I introduce my report, I'd add my thanks to Peter. As the Chief Exec, I will be looking for a new Christmas morning buddy to tour the hospital with. So if anyone wants to take over that role, please let me know. There's more in report than normal. People have got the report in front of them, but I just want to draw out some key bits in the report. So the first thing under our priority of quality mentions Martha's Rule here, a new initiative, really supporting the principle that if patients particularly feel that they're not confident in the information they're being given, the ability to escalate, to have another clinical bit of input. Now, we were very much ahead of this with our call for concern programme that we've started to roll out, but this is going into a national programme, and we've been selected as one of the first wave to implement as kind of forerunners in this work. So it's fantastic in that it provides an awful lot of confidence for both patients and staff who may want an alternative opinion. Predominantly the critical care outreach team are fulfilling that role, and as I say, we've been running it for a little while now with some positive feedback. Following on from our patient story, we heard this, Charlie Farmer's story, and the family have been very much involved in a new initiative that we have in place, which is our Phoenix Room. This is within our children's services and a space that you're able to take children with a palliative diagnosis or end-of-life condition or life-limiting condition into a quieter space away from the hustle and bustle of an ED type of department. Lots of information, lots of things in there to make that experience a lot better. And it's been called the Phoenix Room to symbolise hope and strength, and it was their suggestion that was named in that way. So again, another good initiative within our paediatric services to support those children with particular needs and how we can best look after them. Sticking with children, it's been a bit of a paediatric theme so far. We've obviously now been running our main urgent treatment centre at the Lister site since the beginning of the year, and the plan was always to then move into children's care. We have now made that transition. I've said in the paper here that this is around minor injuries and illnesses, but actually we haven't started the illness bit of it yet, but it's for children with minor injuries. And for that reason, in part, children won't be directly attending, but will be redirected from our ED if it's felt that that's a more appropriate pathway for them than rather than awaiting an ED. And as we know, as we've seen with the treatment centres, both at the new QE2, but also since we opened the one at the Lister, those patients that don't need as intense impact will often get caught up in the clinical prioritisation in ED and can wait longer. And what we've seen since opening, really rapid treatment and getting people home through the UTC. So again, another positive initiative for us. I guess jumping to the other end of the spectrum here, we've been doing some real work around dementia, and we've got a fantastically enthusiastic, dedicated specialist dementia team, and they held a forum open up for carers and people living with dementia to better understand how we can improve, and also have been introducing dementia packs to all of our unplanned care wards to support the staff to be best educated and supportive of those patients with dementia coming in for other types of care, with lots of information to direct loved ones, but also to support our own staff who might need some extra advice. And also under our quality banner, it's great that the Health Service Journal run awards every year with lots of applications from across the country. And our pharmacy team over at Mount Vernon have been shortlisted, and the details are there about a scheme working with Baxter as the provider of a chemotherapy to provide support in people's own homes. And we've heard, again, at a previous story at our board around the genuinely life-changing approach by delivering care that traditionally has drawn people in on a regular basis into our hospital settings, to be able to allow people's lives to not be dominated by that, but are able to be incorporated into their lives. On thriving people, it's really positive here that we've had a load of awards again through the Nursing Times, and I won't read out the individuals. Maybe if they're successful, we'll give them a particular notice in October when those awards take place. But it's been a theme really over the last couple of years. We're getting national recognition for teams across our organisation, clinical teams. People will remember our security team won Security Team of the Year in an award, and other individuals. So it's really great that people are getting the recognition for that. Already mentioned the teaching hospital status application. We had hoped by this meeting we would have been successful in getting that designation, but the general election came in the way, and obviously everything goes on a bit of pause. The team are back in touch with the Department of Health. Oh, and then there was light. In touch with the department, and now that new ministers are coming in and the summer recess is finished, we believe we should get a response on that pretty soon, and really recognising that the large volume of training we do through a number of institutes, including the University of Hertfordshire. And again, we await hopefully their designation and opening as a medical school, for which we've already signed up to be a key partner. And I've also mentioned in here, at a time when we spend time in the board looking at our vacancy rates, and we know nationally the NHS has a significant vacancy challenge, to say that we've over the last month had 25 student midwives go through in our qualifier, and of those 23 have chosen to come and work for us when they could have gone in many different directions. So I think it's real credit to the team and the environment they're creating, and it's brilliant that it puts us very close to full establishment now in our maternity services, which isn't a story that many across the country could tell. Seamless services. I'm not going to necessarily draw out anything particularly here, other than to just touch on the fact that frailty is a priority for the whole integrated care system, because we know with a growing ageing population and the complexity that frailty can bring into people's care, all of our partners need to have a role in that, ranging from how do we keep people healthy in their own homes and prevent falls, that we know are a large driver of people coming through into our service, but right into the hospital setting. In a traditional model of admitting people from ED, we believe that, as we've seen with a number of our ambulatory services, we can maybe turn some of those patients around with some intensive input, working with our partners here at Hertfordshire Community Trust, to get people in their own homes and provide support in that setting. So lots of work going on, and just this week we're piloting a couple of new initiatives as we speak around a kind of frailty unit at the front door, and also changing some of the focus around our frailty ward to really focus on rapid turnaround of our patients. On continuous improvement, we often talk about both the digital agenda we're working on and a genuine digital transformation of our organisation, and as part of our more improvement work using our production system, we've recently gone live with our maternity electronic patient record. That's a forerunner for the bigger electronic patient record we're developing over the next year. What's very interesting is I think we've got a lot of learning from this initiative. I think it's gone extremely well. But with any major change like this, when people have worked in a certain way for a long time, it is a big change, and taking people through that change is important. But I have to commend the digital team and the maternity team, who are nominated for multiple awards in our monthly Values in Practice Awards, for the way they approach this, and it's been a really positive experience for the staff involved, and it will allow patients to have far more access and control of their records in an electronic form rather than the traditional paper-based approach. And then the last thing to talk about, we update really most months about our production system, which is based on the Toyota production system, been in place for many years. Part of that is our positive leader rounds, which the execs are very active in now. So we're regularly visiting what we would call the Gemba, or the place where the work happens. And non-executive directors are increasingly going to be joining us in that work. And I have to say, just from a personal perspective, being on a number of our wards recently and just seeing the fantastic changes that staff are making without being told to, without being given the solutions, real innovation happening and a real buzz around our staff being involved. So it bodes well. I did my introduction training this week, along with another dozen people in the room, and we've now had well over 300 people go through that training. And the leadership training that's far more intense, that a number of my colleagues have already started and are now realising how much homework there is to do. And it's a big commitment, but it's a big commitment because of the commitment this board has made to the hard yards that this is going to take to transform our organisation with the ambition of being one of the leading trusts in the country. So important work, and we're really seeing some enthusiasm for it. So that's all I wanted to say. Thank you, Chair.
Great, thank you, Adam. And just to reiterate that, I think those visits, those lead arounds are really important, and indeed I will be our non-executives will be joining those, and I think we have a meeting next week to sort that out. But no, I think certainly the sort of the preliminary, not formal ones I've done already, I'd completely echo what Adam is saying, that there is a real buzz there, and it's actually great to see people feeling that they can take ownership of problems and sort them out themselves, and I think that's really powerful. So yeah, really very much looking forward to that. So thank you. Right, if any questions or comments on Adam's report? I don't see any. So thank you for that, Adam. Moving on then, our next item is about the Workforce Race Equality Standard and indeed the Disability Equality Standard. Over to you, Tom.
Thank you, Chair. Yes, I'll take them both together in a short summary, and then obviously happy to take questions afterwards. So yes, we have published in the pack for you to review both the race equality standards and the disability equality standards. The race equality standards, for those that maybe aren't aware, the race equality standards was set up in 2015, disability equality standards in 2019. Essentially, it's to provide kind of a direction for organisations, focus on metrics that can be benchmarked to really drive performance and make sure that accountability is held in the right place. The measures are broken down into sections that look at kind of relative likelihood, and it covers areas from things from feedback through the staff survey, things based on our employee relations database, as well as recruitment. In terms of the method, we've got our staff experience and equality, diversity and inclusion team that work together with our workforce information team to pull together the information, but primarily the actions and feedback that's gone into the report has been built much wider across the organisation through our networks, through work that we do as a system, where we've got a system coordinated approach, and we've sought feedback already through our various committees, including our trust partnership and people committee that have already first kind of reviewed the paper. So just to kind of pull out a few key areas then, so focusing on the race equality standards first, a quick note on language. The way that the race equality standards are set up, it looks at BAME and white. So BAME is black, Asian and minority ethnic, and that's the way I'm presenting it, but obviously we recognise that represents a very diverse community itself. One of the areas particularly of focus is equity and access to development. The report shows in the table that that's at 0.8 and has been for the last 2 years, but we should recognise that previous years before that it's been proportionally higher for white staff. So we are pleased that that is going in that direction, and frankly should continue to drive in that direction for some equity over an increased period of time. Another area just to highlight is around representation and diversity, particularly around senior levels. So there's a section in the report referenced as the model employer data, and that looks at specifically Agenda for Change bandings from 8A right up to very senior manager levels, and the breakdown at that level. Now, when you look at that as a group, it is increasing year on year in terms of the representation at senior level, but then it is also variable when you break that down to different levels. And of the 6 levels, 50% of the target has been met, and there's 50% where we still have further to go. And it's worth highlighting, as much as we are having a change around very senior manager level, that's a particular area of focus for us as an organisation. In terms of formal disciplinary, disappointingly, we have not been where we needed to be with that, and it has the metric has worsened in the last year, and I'll come on to more information about actions that we're doing in relation to that. Equally, appointment from shortlisting, which has gone from 1.3 to 1.4, is also one of the areas that has kind of deteriorated in performance. It is worth highlighting that the metrics relating to staff survey have broadly improved, which we take as a real positive. However, there is still a disparity in experience that we must accept and continue our focus on. So in terms of key actions, there's very much around kind of how we're developing our culture, making sure we have an inclusive culture. We have our people strategy, which is the backbone of that, but more recently we've launched our equality, diversity and inclusion strategy, which holds the overarching action plan for the trust, which covers all kind of protected characteristics, but has a very clear statement around us as an anti-racism organisation and where we need to drive our focus. Part of that as well is about embedding the values, and we've heard our values come through quite a few times in the conversations that we have, and making sure they are clear and explicit and understood within our organisation, and that behaviours are understood. And we've done that through our values charter that has been implemented across the organisation. And now, as part of our positive leadership walkarounds, we are encouraging further conversations about how that charter is being used in practice. We've been running a civility and respect campaign, which has started with video, which very much has been supported and led from a clinical side of things, recognising the impact from a lack of civility on patient outcomes. And that's been fundamental to our introduction to everyone in the organisation and at key transitional points, and very much embedded within our management competency framework, which is a key criteria for all of our leaders in the organisation to show they meet that standard, as well as very much targeted work linked to our Healthy Teams programme. And we've had great examples of real development in a key area, for instance in maternity, where we've implemented the sort of healthy team principles around focused work. Inclusive recruitment practice, hugely important, and we're currently working on a kind of a 90-day challenge programme to rapidly improve inclusive recruitment practices. That's on the back of already some good work that we've done over the years with our inclusion ambassadors that are absolutely vital in working alongside our panels that do any of our interviewing and are very much part of that selection process right from the stage that an advert goes out, to be able to review and challenge and test if there's any bias that is being built into the system, as well as embedding a standard talent approach. So our Grow Together reviews are very focused about how we support our talent and what development opportunities we offer to staff, and obviously you can see some of the progress of that come through in some of the figures around access to non-mandatory training. And then finally, it's around a kind of a just and learning principle, and that comes back to looking at all of our policies and how do we embed a just and learning principle and practice within our process, specifically within those relating to any kind of formal casework and management. And this is an area that this year we are absolutely seeing what's going to be different around kind of a shift change really in what we're doing, and part of that is a very clear review, triage process and accountability framework around who goes into any type of formal practice, and have we stopped and checked that we had the ability to have a just and learning approach first. A few of the areas within the workforce disability paper, one of the key bits is around kind of representation that we see within that report. Now we do have a disparity based on the numbers that are reported on our employee database compared to, say, when we do a staff survey and those that declare a disability, and we really want people to feel safe and to be able to declare their disability, and it obviously helps inform the information. So we recognise we need to drive up those numbers, but what we have seen in the last year, that some of our early campaign work, and again using our networks that have much broader influence and have got this as kind of one of our key priorities, is starting to change that. And if you look at some of the senior level, the very senior manager kind of declaration rates have kind of stepped up. So a good show of kind of some role model behaviour to say that we're comfortable in talking about any longer term condition or disability that we have. Also some improvements when you look across the staff survey metrics linked to bullying and harassment. That's really positive to see, but again we must recognise there's still a disparity between someone with a long-term condition versus someone that doesn't have that. Equally, equal opportunity to career progression, that has been highlighted as something that we need to drive more improvement in. So again, I do want to give a call out to our network, the ENH Able network, that have been supporting some much wider organisation initiatives, as well as looking at policy and kind of how we are supporting with reasonable adjustments, and that's driving some positive change, and particularly around kind of the declaration rate. Focus around career progression. When I talked about the Inclusion Ambassador programme earlier, we have been over the last couple of years really expanding that. We have more Inclusion Ambassadors that are there to represent around kind of disability as well, and that's very much being fed into that 90-day challenge piece of work that I was talking about, where we can set up and run interviews differently. And some of the things that we're trialling within that is how we set up the interview with very clear model answers, consistent questioning, and giving the opportunity for some people to have advanced notice of questions before going to an interview. So that's something that will start to be piloted in areas. We have some quite targeted development programs, and something we're quite excited about is working with university partners around a project called Project Search, which is looking at people with autism and learning disabilities, and giving them different access into work. Finally, just to mention around our Freedom to Speak Up Guardian, that plays a really fundamental role in all of this, and her kind of expanded network with her kind of representatives, ambassadors that work alongside her, has really helped us to highlight issues early and then quickly, rapidly drive improvements, and I work very closely with Sylvia on that improvement work. I think that's all the things I wanted to highlight, and happy to take any questions. Thank you.
Questions or comments for Tom?
Thank you. Two questions from me, Tom. And I'm not putting you on the spot with a real exact number, but in terms of those people entering a disciplinary process, broadly, how many do we have a year in the trust? Because I'm conscious, I can think of one case we took through, there was a group, and actually a number of them would be classified as BAME within this. And something like that, if we've got a small number going through, could suddenly make that look like 10, rather than being a level. Now, I'm not in any way dismissing we've got an issue, because year on year we're not where we want to be, but understanding we're moving from a 1.4 to 1.9 type of thing, how statistically significant is that? Because if we're putting 200 people through every year, there's more confidence in movement, but if it's a small number and an incident like that, it could throw it. So that would be one question. And the second question is linked to and it's encouraging to see actually the disability metrics we've seen some real progress in, but I guess covering both of them, and it might be one that Justin wants to respond to or may know the answer. The one bit of our recruitment process that's kind of legal is our consultants, and actually in many respects we're kind of hamstrung a bit in the process with things that are in legislation and we have to work through. Are there any bits in that process, do you think, that might limit us from doing some of the things you've described? So could, for example, we move to a process that says, if we believe there's good evidence that giving people questions in advance is the right model, we could do that for our consultant interviews, or are there bits in that process that would limit our ability? Because maybe, it's a hypothesis that that process is a little outdated. There's probably not an appetite for government to want to open legislation because it's not going to be on their priority list. But I just wondered whether we're hamstrung a bit.
Yeah, thanks. The first question around some of the casework, you're right, it is quite small numbers. We don't tend to have any more than, say, 10 at any one time. So a slight variation would make a big difference in that kind of relative likelihood. That said, when you look at the longer term trends, and that's the benefit we've got now of the RES particularly, I mean, we've been doing it for 8 years, and it's been consistently disproportionately one way, and I guess you would expect to see it fluctuate above and below the 1. So we have to recognise that there is something there to address, and where that starts from. And as much as there is the process side of things where we review what goes into formal casework, actually I think there's something far more, and this is where I started talking about the culture, in that it often starts with really an understanding of each other, recognising kind of difference, and it's when relationships can start to deteriorate early, and then sometimes the easy resolution might be, well, that goes down some formal casework as opposed to good dialogue and management. And I think that's the bit where the more we focus on good quality management, good quality conversations, performance conversations, starts to really shift that. You've got to do both. You've got to get the process working as well as it can, get the culture working as well as it can, and the performance, the management expectations really clear. But you're right, it really can shift. That's one of the ones that can shift year on year. And you look at the disability, and it's probably to do with the low disability declaration rate. We've got a 0 on that because we haven't got anyone with a declared disability that's happened to go through formal casework. But if we had one person with disability, that number would change quite significantly in the next year's report. The second one was about the consultant interview process. Now, it is one where we have less flexibility because it is determined that we do it in a certain way. That said, there is room to manoeuvre within that. So there's nothing to say, for instance, the bit that we're doing around model answers and early sight of questions, we can do that. So the things that are more kind of fixed are around the constituents of the panels and that sort of thing. So yeah, there's potential to do more within our consultant group as well.
Thank you. So, Tom, I think for me the really concerning one is the 8 for racial, under the racial report, which is a percentage of BME staff personally experience discrimination within the trust. I think that, to me, is a number that I'm a little bit worried about. And I suppose my question is, how much of that do we think is historical? So is that staff that have been here for quite a long time? Is it possible to ascertain any of that? Is it specific specialties that we could target? And the third one is, are we sure that that's not affecting patient care in those areas as well? Because often there is a link between the way that we see people in our teams and then how we treat patients. And also, how long do you think, if we carry on the way we are, how long would it be until we have parity within that specific indicator? Sorry. Apart from that, nothing else.
No, the last question that threw me a bit. I was like, wow. But I do think some of it is long-standing, and I guess it's how we are responding to hearing, because people aren't always very confident in coming forward with raising these concerns. Where I take some, as much as I'm uncomfortable with the data where it is, where I do take some comfort is what I'm seeing in terms of the types of freedom to speak up issues that are now coming forward. Like I say, with Sylvia and as the Freedom to Speak Up Guardian and the ambassadors, and that role being so much better embedded within the organisation, and therefore the type of cases we are taking forward relating to dignity and respect at work, where we'll be able to tackle some of these issues much more directly, is sending quite a strong message around, that we do not tolerate this type of behaviour. And there is kind of firm action around that. Now, some of that, so that's the kind of the overt bullying, I would say, and discrimination. That's not to say there's things that go on at a kind of more micro level, and that is still bullying, and that is often, not always as easy to call out, but the more we educate and get people's understanding increased in the organisation, build in that cultural intelligence, then I do think that shifts, but that's probably the longer term one. But there are things that where we are getting it reported early, we are seeing patterns, we are able to go in, investigate and resolve quite quickly, and I do think that is going to start shifting that metric. The time that it will bring some parity is quite hard to say and make a commitment to, but I'm assured we're doing the right things, and I think, well, we've got the people committee where we bring in at divisional level, we go into that granular data from the staff survey. We've specifically asked they pull through metrics linked to kind of the race equality standards, disability equality standards within some of the things they feed back in, and I think that's where we really need to be holding the conversation and the accountability, not just with the people team and the actions that we're trying to do, but with the divisions that hold the management responsibility for the vast number of people that are within the organisation. So again, that's another place to monitor and review progress.
Thank you, Tom. Teresa.
Thank you, Chair. And Tom, I just wanted to highlight the really good work that's happening around the 90-day challenge. So the 90-day challenge is really setting out how do we have really meaningful career conversations with black and ethnic minority staff, mostly on the nursing midwifery side, and it's starting to give some really raw and honest feedback, which I think is going to drive our processes, and that's really being supported by Roomba and various members of your team, Tom. And I'm really proud of the fact that we are going to have an NMC panel now, so it will no longer just sit with one person in a room thinking, how do we refer this individual, should they be referred, what is the support around it. It will be a proper structured panel with our EDI lead, so trying to make sure that we're really challenging fairness at every opportunity, but doing it through a structured lens. I mean, I think the 90-day challenge may well be the 900-day challenge, but we're going to keep going. And just to thank Tom for Roomba in particular support, and also Sylvia's support to do this.
Thank you, Teresa. Diana.
Thank you. Diana Skeet, Non-Executive Director. Thomas, it's just good to see all of the things that you're doing, both in terms of development of strategies, the policies. As there's always a fine line, isn't there, between the kind of the structural and the systemic stuff and the as well as the practical. I'm just wondering what kind of challenges are you having with that, particularly also looking at it from in terms of impact. So how is it actually affecting on the ground? So do people actually feel that you've got the strategies in place, you've got the policy? Do people who are having to administer that understand, how it works? And are the people who are actually on the other side experiencing it, is there a mismatch? Is that going in the right direction? And do you think there's enough training and support to enable that to happen?
Yeah, thank you. So I think this type of report is really important to sort of highlight and focus the issues, and this is being well communicated. Like I say, we've got various groups where we're taking this data to. In terms of some of the teams that sit behind the policy, again, that's largely a lot of people in my people team. We've gone through this, information and data in a lot of detail and had really open and frank discussions as a wider team. I guess in terms of how is it impacting people on the ground and getting that sense of, is what we're doing making a difference? We've got our most established network, previously referenced as our BAME network. We've called it Reach Network now, which stands for Race Equality, Race Equity and Cultural Heritage Network. It's new, just getting used to saying all the full name. But that has been, I happen to sit as the sponsor for that network. We have some really great chairs that co-chair and lead that group, but really, really important input. And again, that is a key reference group for anything that we're doing or changing, and that's where we're getting a lot of really direct feedback, and actually, frankly, a lot of challenge, if we're not seen to be going far enough or fast enough. So that seems to be working quite well as a kind of test ground. I think there is still a little bit more, there is more that we're doing, which is referenced in the EDI strategy. So one is about accountability and having an EDI kind of steering group well established where we can bring in some of those divisional teams. So that is due to be going live towards the end of this year, October, November. We've got all the terms of reference set up, and that will again feed into the people committee, which is a kind of another layer of accountability on top of that. And there's also a real key piece of work again to test some of this is we ran a reciprocal mentoring program last year, and every one of the execs around the table were part of that, and we had several senior managers, and it was about partnering up with people across the organisation. We were looking at disability and race as a kind of a key kind of difference, and understanding kind of their experience of the organisation day to day, but actually then learning together and working together on how do we make improvements. But that series of events, it was hugely enlightening to really understand how the things that organisation and management do and how that kind of then impacts on the ground.
I don't see any other questions around the table, so if I could just make a few comments. First of all, that EDI steering group that Tom's just mentioned, I've actually asked, or did I volunteer? I can't quite remember which way round it is, but I've actually said I will take the chair of that group, and I see the remit of it is about. It's about how, to what extent are we implementing the EDI strategy. We have a good strategy. I want, exactly to your point, Diana, I want to see it having a difference, and I want people to feel that it's making a difference. So I've said I will take it on the chairmanship, at least for the initial part of it. At some point I will hand it over to one of my fellow Neds, but I want to get it on the right track, as it were, which is so that's something I'm personally committed to doing. I did have a couple of questions or just about some of the data in here. 3 questions, I guess. The first one is so it's a really good report, and there's clearly lots of progress, and I think there's lots here that we should be proud of. My first question, if we look at the DES data, the disability data, there are several metrics where we have absolutely got improvement, but we clearly have discrimination built in. If I look at metric 4 in the DES, which is about the percentage of staff experiencing harassment and bullying, there's something like a 7 to 8% difference between those with a long-term condition and those that don't. Now it's improving, but that 7% is still there. And there's a danger, because we're trying to deal with so many things, there's a little bit of a danger that the things that appear to be improving, we think, oh yes, there's some green writing in that box, we don't have to think about it. And I want to keep us challenging that. So it's good that it's improved, but there is still a 7% difference there. So I don't want us to lose sight of that. So that's my plea, if you like. That's plea number 1. Plea number 2 is another area which was actually in the RES data where, and you mentioned it, about the fact that access to non-mandatory training, which used to be that people of an ethnic heritage seem to be not accessing it well, and it's now down to 0.8. Well, that's good, because it looks like people of an ethnic heritage are now accessing that training. But actually, we've had 2 years now where people not of an ethnic heritage are now not accessing that training. So you've actually got the thing going the other way. What we want is parity. So again, it's something that it is an improvement in terms of, if you like, ethnic heritage staff, but it's now the opposite for our white staff, and we mustn't lose sight of that as well. So again, just a plea that just because a piece of data looks like it's moving doesn't mean there isn't an issue. And to me, that there's a 20% difference, that's an issue for me. I want to know why white staff are not accessing the training as much. And my third point was that I am aware that nationally there's been a new pilot of RES data for bank staff. I don't know if you've come across it. I don't know if we've got any plans to get involved in that, because my suspicion is that any discrimination or lack of inclusion that we face generally, I have a horrible feeling that's going to be quite significantly accentuated in our temporary staff, and it would be interesting to get that data. So just your thoughts on that too. Thanks.
Yeah, I'll go back to front if that's all right. we do, yes, there is the bank res data. They've been a little bit more relaxed around who is doing it at the moment. I'm sure it will be quite clear, mandatory going forward. The reason they're being a bit more relaxed is because it is so variable in terms of the way people run their banks. So, for instance, we have an outsourced bank provider, and we are trying to work with them to run the res data for us, but they are not set up like the NHS and don't use the same sort of database, so it's proving really, really difficult. But I think you're absolutely right. It's an area that we're a bit blind to, and we shouldn't just, and they're a fundamental part of our workforce, so we have to keep working with that provider to see how they're going to give us that information. So I think it's a really key point you highlight. And even we have asked for data before, just in terms of representation numbers, rather than things like likelihood to be appointed and casework and things like that. And interestingly, if you're in a bank role, you're far likely to be from a black or Asian or minority ethnic background than you are if you're in a substantive role. So even that tells a bit of a story. So it is interesting. But the other kind of metrics around staff survey and likelihood, that they are the ones that are hard because they use very different systems to us. I agree. Well, I looked at the report and I was kind of, we're trying to, in a simplistic way, saying improve or not improve, and that one, you can argue either way, can't you? Because I guess the optimum you say is a 1, because that means it's equal likelihood to get it. But I suppose where we went with the improve, I guess, where is recognising the previous years of disparity in the other way, a couple of years going in favour of it. But I guess if that then becomes a longer term trend, then we have got something to kind of look at. But like I say, I think it's likely with the numbers that we're dealing with, you'll have a kind of a 1 in the middle, and you're likely to kind of bob and up and down below that line. I think that's
great. Thank you. I don't see any other questions or comments. Thank you for that, Tom. Now, this paper, or these 2 papers, I should say, are for our approval. Are we happy to give approval to these papers? Thank you very much. Thank you. Right, moving on then to the quality account. Teresa.
Very long document, but I am pleased to present this to the board. And what it does do, this document really pulls together the board to ward and the ward to board metrics that you would expect to see in a quality account. It takes us through the fundamentals of care that we touch on and has been touched on earlier on today. And we might do a little bit of detail there as well. It takes us through the alignment of the trust priorities and East North Hearts production ambition as well, and then takes us through our scheduled audit programme, which we are obliged to report on. And also gives us some feedback. So we'll see in the pack feedback from Health Watch, from the ICB, who are the arbiters of this document as well. So the validators, if we like, in terms of what we're reporting on. And I think what it does is it gives us a really clear insight into the future and how we build for it across areas like the accountability that we will have around PSURF, how we take forward particularly the patient's voice and patient experience, because that's one of the areas where we've not been so successful in. So a big piece of work going into across 2024 and into 2025, but also some really good green shoots, that constant focus on fundamentals of care, on improving sepsis. Our Chief Executive earlier talked about call for concern embedded in everything we do. So trying to create a service that is responsive, but also looking forward for our patients. So I'm very pleased to provide oversight of this account today. But I think finally what I would just like to say is this feels like it's moving in the right direction. And in some ways the account is slightly out of date, so we no longer have a 29A, of course, on our maternity unit. We are en route to good, I'd like to think. We are driving our processes around the RI, and you'll see also in there a clear line of sight into the well-led, the reporting of quality standards, and also the oversight. So I think the final point that I'd like to make is that going forward, and you'll see in the detail here, both in page 37, through from page 8, that golden thread for over the past 24 months, 12 months, and then across into 2025. I think the other bit that it would be remiss of me not to point out is this is all hinges on our staff. So the people strategy linked into the quality strategy, linked into our ambition to be a good and outstanding organisation. But I'll stop and take questions, Chair.
Thank you very much, Teresa. Questions or comments? Adam.
Thank you. And I'm going to follow the theme of putting people on the spot, and I'm going to look to Stuart on this one. So I think there's some real rich data in this report, but I just want to take us back to the process, because if you like, when quality accounts first came out, it was really that principle of we get financial accounts every year, it's well established, but if the NHS is about providing quality, how can we give that kind of external view to the public, particularly in the same sense of this is what we should be doing, this is where we are, and work through. I think, as often with some of these national changes, it becomes a bit of an industry, and there is a risk in, we have a very long report here, and if there is a risk in good governance that we don't see the wood for the trees, I'd like to think next year we can take more control over a process that in the past has been, this is the format you have to use. So it's just understanding from Stuart, because I know the rules were more prescriptive about what we had to report and what we didn't. What is the flexibility we have as the team start to work on next year's quality account already? Because I'm keen that it is important for the board to take assurance, but it should be a really crucial public-facing document, and recognising things as we've discussed before. If you look at the national reading age, if you look at the ability to access data and interpret stuff that we're very familiar with, a kind of 120-page dense document may do the job for us as a board, but it would be great to think we had more flexibility. But you might tell us, no, there's nothing we can do differently, but I think there might be some more scope. So if it's not putting you on the spot, it'd be helpful to know.
So first of all, Stuart Dalton, Head of Corporate Governance. The main thing is that the main change is that the equality account is no longer reserved to the board, no longer mandated to be reserved to the board. As a trust, we have chosen to do that because of the importance of quality. In terms of the actual elements within the quality account, that's one I would need to take away in terms of what is still prescribed. I don't know, Teresa, if you have an understanding on that.
So I do understand that we are obliged through the legislation of the Health and Social Care Act to report on all never events, to report on compliance to key national audit parameters. But I agree with you, Adam, we do need to look at how can we come up with something that is much more user-friendly whilst not losing any of the content, which could be managed at a more local level. We do know that foundation trusts are no longer obliged to produce quality accounts at all, but I think there is more information coming out, I believe, November this year on the well-led aspects of this.
Thank you. David.
So thank you. I just simply wanted to add something we've discussed before is people put a lot of effort into these reports. They really do contain some good stuff. So it's just how we make them useful, how we make that one-pager, two-pager, how we use it as comms, how we tell other colleagues in the NHS and how we tell our patients. And it's my yearly challenge, but I actually think we all struggle with it because we do. I guess I would heave a sigh of relief once I'd finished that amount of work, but to make it useful we need to do a bit more.
Thank you. Any more questions or comments from anyone? Nina?
Just one question. So I know we wanted more patient experience feedback, but we're not doing proms. Are we thinking about doing that, or is that a...
Yes, absolutely, Nina. And I will say that we have, on the back of the National Patient Survey, National Cancer Survey, we've instituted a weekly patient experience committee that is really focusing on making sure that we take every opportunity. So proms for hips and knees will be back on track, I believe, the back end of this year going into 2025. And we do need to make sure we're really, as David was saying, explicit with all those findings so we can drive those improvements.
Thank you.
Any further questions or comments? No? Okay, so then just to wrap up, so I mean, my thoughts on it, I think this tells a really lovely story. I think there's some lots here to really be proud of, and I think, by the way, it was a really nice touch to have that independent view at the end from the ICB, even from Midbed's health oversight scrutiny and Health Watch. I thought that was a really nice touch. I tend, however, to echo Adam's comments. I think we need to make sure we understand who our audience is, and if our audience are the general public, this is beautiful, but this isn't gonna do the job. So hopefully this new guidance will help us, and it may be that this is the thing that we produce, but we then produce one of those 4 or 5 page summaries or something. I don't know, but there's lots here. But it kind of felt like we maybe had too much in some cases. But it was lovely, and it was lovely to read it, and absolutely our congratulations to the team that put this together, because this is a serious piece of work. So I think it's been done really well. If we have no other comments, this account is for approval by the board. Are we happy to approve this as our formal quality account for this year? We are. Thank you very much. That concludes that item. Now, in a change to the advertised schedule, we have a slight change. I don't know, Teresa, if you want to say something about. We were going to go into an item about PALS, but I'll leave it to you, Teresa.
Chair, thank you for that. What we would like to do is bring back via our Quality and Safety Committee a full update on patient experience, of which there'll be a section on PALS and the national surveys, and that will come through our committee structure before it comes to the board, if I may.
That's fine. I think it's right that we have the proper governance around this, so I think that makes sense. Thank you very much, Teresa. In which case, we're going to take a 10-minute break and start again at 11 o'clock, please. Thank you. Right, welcome back. We are moving on to item 12 on the agenda, which is our integrated performance report. And I will do my normal, which is that we'll take it in the 4 sections at the end of each section. So if the executive director talks about the section, I'll ask the non-execs from that committee if they have any comments. We'll then move on to the next one. So we'll take it in chunks, as it were. So quality appears to be first up. So Teresa.
Thank you, Chair. Delighted to make a wee start on the quality section. What you'll see in the quality section is that we have sustained our improvements both in pressure ulcer prevention and in fall, so I'm really pleased to report that. And through our harm-free care initiatives, we can see that that's definitely moving in the right direction. For C. diff, we have actually 40 today reported C. diff cases, but only 2 of the cases, 2 of that 40, are preventable. So that's quite reassuring that we now have that data. We've worked very, very collegiately with our colleagues at the region, and they have now increased our threshold for compliance. So you will remember our trajectory last year was about 57, and this year it's up to 92. They recognise the work that's been done. They recognise that we are working consistently on prevention of C. diff transmission, and they can see that this is as much a community challenge as it is an acute hospital. You'll also see the data on sepsis there. Sepsis and ED, I think, pretty well sustained given the challenges and the pressures in ED, but this is a constant focus for us. We have a weekly sepsis improvement group chaired by one of our directors in the division, and you will see lots of sepsis activity over the next 2 weeks as we get round all of our wards and departments again. A bit of a drop-off around antibiotic administration in our ward areas, and a bit of a drop-off on our lactate samples, and a little bit of drop-off on urine measurements. So each and every case is monitored, it's enhanced, and we do make sure that they are followed up. What we're not seeing is a read across to any mortality implications, either for sepsis or for C. diff, but really proud of the consistent work that's been done there. I'm going to hand over, I think, probably to Justin, our medical director, if I may, for HMSR.
Thank you. Teresa and I have been working really closely together on C. diff, and I've been chairing meetings with each of the clinical teams as each patient has come through with C. diff, so that we can understand as much as possible about that patient. People around the board may or may not be aware there are 3 things that make a C. diff case more likely. It's the age of the patient, it's prescription of broad spectrum antibiotics, which are often needed at the start of sepsis, and it's also being on a proton pump inhibitor, so a drug that reduces the acidity within the stomach. So we're looking at all 3 of those things. The key with the antibiotics is to narrow the spectrum very rapidly. You have to start with broad spectrum when you don't understand the cause of sepsis. But the PPI bit is really interesting, and we're actually going to do a background audit to see what proportion of our elderly patients come into hospital on a PPI. We think it's very high anecdotally. We need to find data about that. If it is high, then we need to work with primary care to see whether there is a possibility of reducing that number. I was going to talk briefly about our mortality figures. You'll see that our crude mortality is in a relatively good place, and our SHMI and HSMR, which are both markers of mortality, mark very well compared to our peer hospitals. The really important bit for me about mortality is how it correlates with length of stay and readmission rates. And those people who've been on board for a while will have heard me talk about this previously, because actually it's no good having a low mortality if we then have a high readmission rate, or if we have a very long length of stay. And the good news is that all of those metrics are where they should be. And when we look at the standards that we're setting, we're doing reasonably well with all of those things. People on the board will have also heard me talk previously about the average age of patients we're admitting to the trust, and this continues to be significantly higher than the national average, and therefore again looking at this data with that in mind also is reassuring. We currently don't have any 3 standard deviation outliers or mortality, which is really helpful. Nina, you brought up a question at a previous meeting and I fed back to you around cardiology. Just very briefly, what I fed back to Nina was that you'd queried the acute myocardial infarction death rate within the organisation. I've looked at the other cardiology markers, and I've also looked at the overall cardiac deaths. The overall cardiac deaths benchmark well compared to other peer organisations, which then leaves the question, what are we seeing within that data? And the answer is that it's difficult to code for different types of cardiac mortality. There is a natural overlap between them, and when you look at the other coding categorisations, they are much lower than they should be. And I'll stop there, but I'm happy to take questions at the end.
A little bit clunky, but we'll get there. Thank you. Any questions or comments for Teresa or Justin? Peter.
Yeah, thanks, Chair. I just wanted to mention the whole issue to do with infection and prevention. It's one of the committees that I've attended, and believe it or not, I actually enjoy it because you get to hear about a lot of good work. But it's something, I know this is not lost on the board, but you really have to keep your eye on, because at any given time things are popping up. You know, you tie off one thing. We've done well with C. diff over the years. Then you've got, I mean, yesterday Lorraine and team were talking about getting themselves geared up in case of Mpox. We know about COVID. And then not just for this trust, but for the NHS, the whole issue to do with microbial resistance. There's a whole range of issues. So it's a committee, and the team do need that support and that focus. So I just thought I'm probably saying the obvious, but I thought it was worth saying.
Thank you, Peter. I'm going to come to David as Chair of Quality and Safety. I don't know if there's any other comments you'd like to make.
No, I don't think so. I've been reflecting on the comments about it is something that's been looked at generally, and I think I was going to ask Justin to bring that topic back, because in my previous life I'm aware that the community does try quite hard on this area, but just about everybody gets on these drugs, given time. So we'll take that action.
So if there are... was that... No, you weren't. Sorry, I thought you were sort of... Okay, fine. All right, just a waggling. Okay, in which case, can we move on to, I think it's operations next?
Good morning, I'm Lucy Davies and I'm the Chief Operating Officer. This is my section. This report is for July 24, but I will give you some highlights from August as well across all the operational domains. On urgent and emergency care, although our 4-hour performance in July was very similar to that in June, in August we've had a really strong focus and push from executives as a team and throughout all those staff involved in urgent and emergency care, and we finished the month of August at 73.3%, well into the 70s. It's not yet at 76, but as we stand today in September, we're at 74.9%. And this is the result of ongoing focus, work on the culture and leadership and roles both within the ED and through associated pathways and up the escalation chain, and also some great work on clinical pathways led by Teresa with multidisciplinary input, where we've managed to clarify and simplify and sign off a number of either ED avoiding pathways or direct to assessment pathways and direct to imaging pathways for more of our patients. So this means that our patients are statistically safer now in ED than they were, although we accept we still have a long way to go in terms of continuous improvement there. We continue to drive down our ambulance handover times, and it's interesting to note in system discussions, Herts and West Essex, all 3 of the acute trusts have driven down their ambulance handover times in a kind of steady way, and however the ambulance services category 2 response times, which is a very strong focus of kind of national measurement, haven't improved at the same rate, and that's dissonant from other ICSs within East of England. So there are some other reasons, as well as handover delays at hospital for ambulances response in the community, and those are being explored. There seem to be some particular staffing challenges for our ambulance service in this part of the region because there's competition from services with London Waiting and others. Moving on to cancer, we continue to have steady and strong performance in all 3 of the nationally measured targets, and 2 of those 3, 31 days to treatment and 28 days to diagnosis, have showing steady and positive shifts and compliance over a statistically significant number of months now. And the 62-day performance tends to hover just under or just over the target of 85%, and is an area of continued focus and achievement. Indeed, we've been asked to and have given webinars on our targeted pathway management in cancer to other teams in the region. On referral to treatment times, we continue to progress steadily towards both 65 and 52-week targets. We've been flagging risks to full delivery of 65 weeks at the end of September, and some of those risks sadly have materialised, particularly in trauma and orthopaedics, where the volume of trauma, some localised equipment difficulties, and also subspecialty pressure mean that we're forecasting about 70 patients who will not have been treated by the end of September. We're not alone in forecasting those sorts of numbers. In fact, all trusts in the East of England, all acute trusts, are forecasting that they will not meet 65 weeks at the end of September, and we are at the better end in terms of lower numbers forecasted than many other, and lower numbers forecasted than both other trusts in our system. However, it's an area of continued very strong focus and need for some further pathway improvement work, particularly in our elective orthopaedic pathways. On diagnostics, our position is improving, with the exception of audiology pathways, which you'll remember we returned to reporting a month or so ago, and with the continued service pause for the majority of paediatric audiology pathways, workforce and estate challenges. We're in the process now that we've got a few months worth of capacity information to do full trajectory work, so that we can confidently set out recovery trajectories in both adult and paediatric audiology in the weeks to come. There will be support needed we will continue to need mutual aid support in paediatric audiology from system and regional partners. We know that remains a challenge, but we continue to push for that. We will also need to work on how we focus more of our project management, business intelligence and administrative resources to that team in the short to medium term, to enable the delivery of both trajectories and the booking of additional clinics to deliver those services. We're making progress on the options for outsourcing some of the simpler adult audiology cases, and that will be coming to our trust management group tomorrow and on a regular basis as we move into a more of a recovery phase in that area. The other modalities where we have challenges, predominantly MRI, where we have outsourced a number of cases, but we continue to experience very strong demand and increasing proportions of cancer patients on cancer pathways with requests for those services. Also sleep studies and endoscopy, where we keep very close eye, but we've seen really improved performance in CT recently, which means that we hopefully will be able to deliver compliance with 6 weeks in our diagnostic specialties other than audiology and potentially MRI by the end of March of next year. Finally, on stroke, we hold our improved performance at a B rate or at a B score, but flag the changes nationally that are upcoming to the SNAP audit database definitions, which are likely to impact negatively on our performance post-October and will require some more resource to address. Happy to take questions.
Thank you, Lucy. David.
Well, first, just to recognise how good it is to see a B SNAP rating. That doesn't mean there aren't targets and challenges, but my question is really about waiting lists. So waiting lists are a problem for us, patients, and a national NHS problem, so we've got to keep an eye on them. You've picked up on audiology, so I'm just going to ask you a specific question about audiology. I mean, audiology is essentially, much of that will be hearing tests, I'm sure. But is there any safety or quality issue appearing as a result of our increasing waiting lists?
I'm going to ask some of my exec colleagues for support in answering that question, because I'm sure that we are, because patients have been paused paediatrics for a very long time now. But perhaps I can pass to either Justin or Teresa.
Thank you, Lucy. I'll make a wee start. I know Justin will want to comment as well. So we have a weekly cadence of monitoring the sort of quality impacts of what is a fairly large backlog at the moment, and there's a paper coming to execs, in fact, next week for audiology for children. But we have got proactive plans in place at the moment. We've just recruited a fantastic new head of audiology who's going to oversee the recruitment, the equipment and the environmental challenges that we're facing. And in fact, only last week we had a very productive meeting with the regional chief scientist to look at how do we get these children through an ENT clinic so that they're being seen. I'll hand over to Justin, who will talk through perhaps some of the risks that we've averted from a quality and safety perspective.
I wonder if it's helpful just to recap, because I realise we've got lots of new people around the table where this problem has come from, if that's okay. Can I just take a minute or two to do that? So Midlothian, about a couple of years ago, realised that they were underdiagnosing, or the national team realised they were underdiagnosing congenital deafness in babies born who'd had their initial autoacoustic emission, so their initial hearing test at birth. That led to a national investigation, and it was found that the rate of diagnosis at East and North Herts was also below where it should be. Therefore, on the advice of the regional team, we paused the work that we were doing in paediatric audiology to give us time to look into it in more detail and make sure that the pathways were safe. There has then developed a national problem, and the national problem is that actually there are problems in multiple sites. Multiple areas don't have accredited paediatric audiology services. Multiple sites have struggled with their training. And this is a pattern that's now developed across the whole country. And this makes it really difficult to sort this out because there aren't enough paediatric audiologists across the country. We haven't trained enough, and we haven't employed enough over the years. I was very keen that, having initially looked, we then started with the appropriate support and safety in place to reopen services. And this was pushed back from the regional team, who did not feel comfortable with this approach, and my concern was that the longer we left those services closed for, the more risk we would build in the process. And I've gone back to the regional team and the national team on a number of occasions to say the same thing. As Teresa reported, we made some progress with this in the last week or so, and we will be reopening our pathway for children above the age of 5 without complexity. Sorry, that's complicated, but that pathway will be reopening fairly shortly under the supervision of our ENT surgeons. And I guess my frustration is that that's probably something we were in a position to do some time ago. So to go back to your question, David, is the risk in having a significant number of children on the waiting list? There has to be. And my frustration is that we've not been allowed to act in a way that allows us to deal with that risk. I think we are making progress, but it's slow.
And can I just check I understand the clinical risk? It's essentially that children will be diagnosed as having hearing problems later than expected.
Or children where those problems are strongly suspected won't have been getting the support they need. And if a child of 4 waits for a year, sorry, I don't have to say it to you, then that's a very significant proportion of their life and a very significant proportion of their time and their ability to learn in school. And often these problems are picked up at school entry or nursery entry. And if we then delay the diagnosis and the support for those children and their families, then we are doing harm.
I could just add one thing, because I think it's important context. As has already been said, this is a national problem, and so part of our response, if we were to have a service challenge, would be we would look to ask other trusts to pick up the patients. But as being said, there are very few accredited units in the country, and as more units are asking for support, there is a problem. I would just say, in terms of our local system, I wrote to the ICB some time ago now, asking whether we could close the service to referrals in order to allow those children to be referred directly to other services. We weren't supported in that ask, because even with our waits at the time, the waiting lists at other services were longer than our poor. So it wasn't the ICB wanting to stop that. They were very supportive of the approach, but actually our waiting times were still quite short. So it highlights some of the challenges. Even where services are functioning, there is a longer waiting time than we would want to be in place in other organisations.
Yeah. Thank you, Adam, and thank you for that discussion. I'm conscious of time, but I don't know, Nina, as somebody on FPPC, have you got any comments on the operations?
No.
Nothing that hasn't been discussed already?
No, and the conversation around sort of A&E and we've had already within the FPCC, so...
Okay, fine. I had just one question. I mean, obviously in terms of the UEC target, I know it's improved in the last month, and I know Teresa was saying it improved a lot in the last couple of weeks. Are we still confident that we are able to achieve 78% by the end of the year? Are we comfortable we have everything in place to allow us to do that? And better, of course, because that still isn't good enough. It's just the target we've been set currently.
I think with the work that has been put in, and as long as we can collectively sustain that level of focus, we should be confident that we'll be able to get there.
Thank you very much. Thank you for that. If there's no other questions on operations, I'm going to move to finance. Martin.
Thanks, Anita. Hi, I'm Martin Armstrong. I'm the Trust's Chief Financial Officer. So looking at the month 4 performance that's reported in the pack, and probably a little bit like Lucy, I'll just give some updates around kind of month 5 as well that we now have kind of available. So colleagues will kind of remember back in June we did finally kind of sign off an agreed plan, financial plan for the year ahead, which was targeting the delivery of a £1 million kind of surplus. That had some quite kind of stretching and demanding components kind of to it, one of which was the delivery of about £33 million kind of savings efficiency target. That's about kind of 5% of our operating expenditure. That's a big number, but actually it's actually slightly less than the national average, if you can believe that. On there, a key component of that savings plan was, of course, continuing on from our good work in 23-24 around elective delivery, delivering more elective activity at a margin, and we did set a stretching and demanding target for that, and that's a key part of our financial plan, but it's also a key part of how we kind of deliver some of the referral to treatment targets that Lucy's kind of talked about, and of course just reduce the number of patients that are waiting for kind of operations. So how are we getting on in terms of delivery against that plan at month 4? We're reporting an actual deficit of £2.1 million, which is about just over £1 million worse than we would have expected at kind of this stage. So the large chunk of that gap relates to the costs that we've experienced June and July associated with kind of the last phase of kind of junior doctor industrial action. So that's both the cost of additional kind of support staff that we needed to bring in during that period, but also income and activity that was kind of lost in there. But we're not currently at the moment expecting any additional funding from the Department of Health or NHSE to address that. So that's a bit of a gap and a bit of a kind of problem. But actually the position below that is a little bit more kind of complicated in there, because we are experiencing, beyond industrial action, some significant hotspots of overspending kind of pressure in the year to date across medical staffing in a range of areas, and some areas of nursing and midwifery kind of spending as well. And that's been a feature consistently kind of during April through to July, and looking at the month 5 position, those pressures continue unmitigated. We have been able to manage those in the year to date through utilisation of some non-committed technical reserves that we had, and that's allowed us to track pretty close to kind of plan. Unfortunately, the scope and ability to do that going forward is limited. So the underlying run rate issue that we have in the year to date is certainly something that the Trust can't continue to run with or tolerate in the remainder of the year if it's serious about delivering its kind of financial plan. So in response to that, there's been a lot of work kind of during August, going into September, working with kind of divisional and corporate colleagues, looking at how we might address those kind of issues, some of the mitigation plans that we might need to put in place, and also some further recovery work streams that we would look to enable and deliver over the remainder of the year, so that we can achieve the financial plan. And I know we'll talk a little bit more kind of later on this afternoon about some of the detail of that. So I think they're the key issues I wanted to highlight from the financial position at the to date, but happy to take any questions.
Any questions or comments for Martin? A good summary there. Anything from FPPC? Nope, that's great. Thank you very much for that. Moving on then to people. Sorry, Adam.
Sorry, just a very brief comment, because I wanted to tie back, and while we report an integrated performance report, the link. So Lucy mentioned some of the challenges around orthopaedics, and the fact that because we've seen pressure within trauma, it's meaning that those orthopaedic surgeons are working on the kind of fractured hips rather than doing the planned knee replacements, for example. The other challenge financially, and it plays through in some of the narrative around, we are still paying premiums for people to do extra planned lists, and yet we're down on the activity. And the double challenge is, because we are funded for our emergency work on a fixed fee, those extra trauma cases are not reimbursed, but they also then mean we can't generate the additional income that Martin has played. So there is a very fine balance in terms of the planning when we see more emergency work coming through that actually has a double impact on our finances.
No, a good point, well made. Thank you for that. Right, if there's no other comments on finance, let's move to people. Tom.
Yes, thank you. So just a quick mention of the vacancy rate. We have seen a bit of an increase over the last 4 months, although obviously July shows a little bit of an improvement. I think just to recognise some of the things driving that. Firstly, we did have a step up in our overall establishment from the beginning of April, and we've seen a little bit of an increase in the last couple of months. So that establishment control part and delivering against our establishment plan is of high importance, and is driving the vacancy rate up slightly. It was also around a conscious decision around international recruitment and to invest internally in the developmental roles we've got within the organisation, and they are coming through, but they're taking that a little bit longer. But actually what we see in the pipeline of new recruits September into October, both with our newly qualified students and some of those developmental roles, particularly where in nursing, where we've seen a more of an increase in vacancy, we're hoping that really turns around from that point. Certainly that's what the data indicates. In terms of the bank and agency control environment, very much linking with what Martin's just highlighted, again, where we had our planned trajectory, particularly around bank. We know we need to do some work to bring that back in line with that trajectory. We do have our internal kind of triangulation meetings looking at bank, e-roster utilisation, sort of the planned deployment, and substantive recruitment, and we're bringing those divisions into those meetings to really understand what is driving that variation, and clearly we have our resource control panel as that overarching kind of structure to make sure that we're not over deploying in areas where we don't have the budget. So and I think that really needs to step up a level going into the next month. Equally working very closely with system partners around general kind of improvement and efficiency we can do around our kind of temporary staffing usage, and make sure we're managing the cost as effectively as we can. A little bit on kind of Grow Together, which is our appraisal for new people to the board. It's the end date was set for the end of August. We know we haven't hit our 90% target, unfortunately. So we are going out with some repeated messages around the importance of that. We are doing significantly better than last year. So clearly the embedding of the new system is starting to really happen, and we do know that the quality of those conversations is really high. We just need to get that compliance rate up, so that will be closing those final ones down in September is going to be of high importance, and we discuss that further at People Committee next week. Also around turnover, so lots of work around kind of improving our culture and generally the staff experience in the organisation, using the staff survey really as a kind of a key indicator of where we need to focus our attention. And certainly with when we look at the voluntary reasons that people leave the organisation, there are fewer and fewer of those that are leaving. Nursing and midwifery is a real kind of standout in that area, and clearly that is our best mechanism, is retaining the talent that we have is really important. So some positive ongoing signs there. Just generally around our kind of Thrive Together element of our people strategy. So staff survey launched as of Monday. So everyone's received the link from Quality Health, our outsourced provider, and we're obviously encouraging everyone to complete that survey. Really important that we get a good representation of our workforce, and we want to improve on our uptake rate from last year. Finally, around kind of Care Together, so our absence rates, we've seen a bit of an increase through the summer months. Now we've drilled down a little bit more into kind of the key reasons. We know we have seen a bit of an increase in kind of flu and COVID related absence. It's not actually the main driver though. It's mental health related sickness absence, which accounts for 22%. So we are looking at where those particular areas are and what more we can do from a kind of an interventional point of view, and clearly sharing our much wider messages around the support that we have in place for staff with mental health related issues, including our employee assistance program that we have available, and our occupational health team that are very good at receiving immediate referrals directly from employees and understanding where we can best direct them for support, as well as supporting managers in those conversations, and building the number of mental health first aiders that we've got across the organisation. But again, more of that coming to People Committee next week.
Thank you, Tom. Any questions for Tom? Oh, Janet.
Oh, yeah.
Is it on green?
Yeah.
Brilliant. Okay. In the section around the Grow Together review compliance, it particularly references band 6 and below, the rates being lower, and obviously those staff tending to be much more patient facing much more of the time. Is there anything in place or any thinking around how to provide potentially opportunity for them to have that quality time?
Yeah, it's partly by design in that we start with a kind of a cascade effect. So we are agreeing our objectives at the start of the year. That tends to happen around April. I think we're reviewing that whole process to bring that even a bit further forward, because once we've got our organisational objectives, that should then feed into our personal objectives and goals. And the idea is that we get all of our very senior managers done in kind of April and May, and then that then cascades down to our more junior roles by June, July, August. So there was naturally a much greater number of people that were due to have their Grow Together reviews in August. So again, it's probably a little bit about working with the managers around kind of how do we spread that out, but equally bring the process that little step forward.
Yeah.
So we're kind of agreeing the objectives early in the year, and I think that's the intention, isn't it, Adam?
Yeah, so we have our next, what we call Leadership Live, away day scheduled in 14th of November. So we'll be looking to set our objectives to then bring back to the board for support kind of the end of this calendar year, which will then allow us to use the last quarter to start that process rather than the first quarter to be doing.
Thank you. If there are no other questions on the integrated performance report, thank you all for your comments. Lots there that actually we should be proud of, that we're making some real progress. Also, some things that we clearly need to keep focus on, but a good discussion. Thank you. Right, moving on then. We are a little bit behind the clock, but the next item is an important one. Welcome Amanda to the table. The maternity assurance report, which is for our approval. Thanks, Amanda.
Lovely, thank you, Chair. So, quite a detailed report in here because this is the start of a recommendation for us to exit the maternity safety support programme. So just briefly to go back to a couple of years ago when we were rated inadequate by the CQC for maternity services, and a huge focus on fundamentals across a range of work streams in response to a 29A improvement notice. Within 9 months following the re-inspection with the CQC, we'd managed to close that improvement notice, and working with our maternity improvement advisors as part of the safety support programme have been looking at the improvement phase of the programme, but working towards sustainability. So the report details, the reasons that we entered the safety support programme, which is any maternity service that's rated inadequate by the CQC, and details our improvement journey. With a focus on the 3 key work streams of the Sustainability Action Plan around leadership and staffing, culture and policy and process. So I've given an update on the progress within all of those work streams. And just wanted to pick out sort of some highlights really, and there's been a huge amount of work done around the estates and environments, which a lot of you that have been visited the unit recently have experienced firsthand, which has directly benefited both women's family experience, but also the staff experience also. A huge amount of work around staffing, and I presented a paper to the Trust Management Group a few weeks ago, which was approved in full, which has agreed an uplift in the headroom for midwives to 25%, which actually puts us as one of the top trusts in the country in terms of our headroom in maternity, to ensure that we're able to deliver that role essential training, which gets more and more with each national report that is released. And the agreement to have a separate staffing model for our maternity theatres and recovery, which was a must-do action from the CQC, and we now have a clear plan and a working party currently working towards a complete separation of those services, working in alignment with separate staffing models by April next year. In regards to culture, you're aware that there's been a huge amount of work undertaken, and I've got a separate report that will be going to the People and Culture Committee next week. But I just wanted to highlight, I think cultural shift is quite a difficult thing to measure. So I've tried to include a few things there that just give us a sense that we are starting to see that shift in culture. Our vacancy rate is now close to 0%. It was around 20 to 25% when I joined the Trust 2 years ago. And the important thing is that we're retaining those staff. So you'll see with the vacancy rates, we've seen a drop, but also we've seen that sustained drop. So we're seeing a reduction in our turnover. Really great improvements in our maternity sickness rates as well, and that's across midwifery and medical workforce. And we did start to see some improvements in the staff survey in 23 compared to the previous year. Our focus moving forward is on really promoting that with our staff, ensuring that they see the value to them in completing that, so that we can start to get that more granular detail this year across the clinical areas to target our further improvement work. Regarding culture, we have accepted support from several external sources including the NMC and GMC, and there's a workshop ongoing this morning around professional conversations with many of our staff that will target reach about 150 of our staff, and we have other external support offers supporting senior leadership and our Band 7 leaders also. Feedback from our trainees is improving. We've been giving regular reports to NHS England's Workforce Directorate and have been on an improvement plan with them for the last 2 years, which has now been closed following our most recent submission and the evidence that we submitted as part of that. We're obviously still on our journey. The Sustainability Action Plan is still in place. From NHS England's perspective, it's not that they want to see everything on that action plan green. They want to see the progress and commitment towards sustainability. So in terms of next steps, we are having a review by NHS England that will be attended by the ICB and a service user representative and one of the leads of the safety support programme in October, following which they will then take our Sustainability Action Plan and this paper through the various approval processes, and there's several steps from system level to national level following our exit of the programme, and we're aiming that would be achieved by December. So I've included various sort of appendix of things around the changes that we've made to the governance structure and the work streams within our EDI improvement board, and the recommendation is that you support our decision, our recommendation of our readiness to exit the programme, and that we start that process working with regional and national colleagues. Thank you.
Thank you, Amanda. Questions or comments? Peter.
Thanks, Chair. I'd just like to say that I mean I've followed this journey over the last 2 years, and I well remember the situation that you walked into, and I mean it has been a stunning success from my perspective. The turnaround, the reduction in the vacancy rate, and Adam touched on it in his report. 23 of the 25 midwives that have qualified have elected to come and work here. And again, I never know how much the non-execs know or don't know, but most of the midwives work in several other hospitals, and there are thousands of vacancies for midwives across the country, so they've got the pick. And for 23 to want to come here, that to me is the acid test. So it's been a pleasure to watch this, and I just hope that you do get out of this and move forward. Yeah.
Thanks, Peter. Adam.
Yeah, just a brief comment for board members' awareness. So when we had the last meeting with the regional and national team, and that's when they first kind of suggested that we should be ready to exit, subject to the points that Amanda's just taken through. I said, well, what does it really mean? What's the kind of benchmark? And their assessment was that they would expect an organisation leaving to be capable of receiving a good rating from the CQC. Now, clearly, they don't have a say in that, and that will be subject to the next inspection whenever that might happen. But I think in terms of the level, the benchmark they would use, they would be saying by recommending or supporting our exit that they believe we're a good maternity unit. So I think that, building on Peter's point, that's real credit to the team and executive colleagues, I think, who have really supported Amanda in this journey to get, and frankly, that the motivation of the staff who really want to deliver great care, and you can feel that quite palpably from the team who are really embracing the improvements.
Yeah, great, Adam, and yes, indeed. Kevin.
I'd just like to say, I mean, the effort that was put in this and the amalgamation of all the teams was incredible, and it worked. I mean, I think it was a bit of a clash at the beginning, but it did work. And this is the way we've actually got to this state, where we've got to this stage, is I think the way we should be managing in totality. And I'm wondering how we continue to hold ourselves to this level. That includes my team as well. How we manage that, how we manage going forward, that we're ensuring that the equipment is the right, that the management of the equipment, the environment stays as it is. I'd hate to think that all the massively good work and that slips in any way, but it is all-encompassing, and it takes a huge amount of time out of the clinical, the nursing, the environmental teams. I think we need to understand that, but I'm just worried that we lose this level. It took a lot of time, a lot of effort on your guys' behalf.
So I think EBME is a really good example. So I think our exit from the programme relies on our commitment, all of us, to sustaining the improvements made. But EBME, we've had real challenges in terms of equipment, and we've been doing a lot locally, and there's been a lot being done in EBME, but our recent success has come from bringing those services together, working really collaboratively. So I think, and I think with the changes that we've made within division and the governance structures and the care groups will help us have better oversight. So there's something about us internally and how we work together, but we will still have that external scrutiny and be held to account by NHS England as we, even after we exit the programme, as we continue with our improvements. But it's that collaboration that's the key, I think.
Thank you. Any further questions or comments? I don't see it. Oh, Amanda.
One final comment, just to say that on Monday I was fortunate to be able to take several members of my team to visit a maternity unit that's been rated outstanding. Come away with lots of ideas, but also lots of things that I think actually there's things that they could learn from us. But the key message, the key thing I've come away with is that could be us. We've got everything here that means that we could get to outstanding.
On that very positive note, thank you very much for that. Can I ask for board's confirmation of approval of that report? I get lots of nods. Thank you very much. Thank you, Amanda, for your time. Apologies that we were running a bit late, but anyway, but thank you. That's great. Okay, we are behind the clock, but I am thinking most of this stuff we can probably take as read. But let's move on to system performance report. Martin.
So I think probably the most important thing from this report is we've got the orientation right this time. On that, so you don't have to kind of
definitely I'm with that.
Suffer some sort of neck trauma trying to read it. I mean, I think as we made the point before, kind of Anita, it is it's obviously the ICS wide version, the mirror image of our own kind of integrated performance report. It is. It does work on a very historic kind of time period. You'll see that actually the vast majority of the data kind of included in here is April, with some smatterings of kind of May and June. So it feels like a little bit of an artifact of history rather than a contemporaneous kind of view of kind of performance. I think I think the value for us within it looks at some of the comparative data that we can see across some of the key headings in terms of progress that others are making or not making around some of the key challenges that we also have around UEC, RTT, etc. But there's nothing I'd want to specifically call out from the report.
Any questions or comments for Martin on the system performance report?
The reason why it's so far behind, do we know? They're looking at their ambulance handover, which is data that's
If there are no further questions, this is for noting. Thank you very much. Moving on then, we have the committee reports. I think given the richness of the conversations we've had and also the fact that several people are not here, I'd like to propose that we take these 4 reports as read unless somebody has any specific questions. So there's an audit and risk committee report, a Finance, Performance and Planning Committee report, a Quality and Safety Committee, and a People and Culture Committee reports. Does anyone have any questions on any of those? Are we happy to take them as read? I see nods around the room. Thank you very much. We'll do that. Which then moves us on to annual cycle, which I think has not changed, Stuart. Is that right? It's as we've seen it before?
It is. The estate strategy was due to come to this board, but it's now going to come to that report.
Indeed. As we know. Then, any other business from anyone? No? Okay. In which case, the date of our next meeting is the 6th of November. That one will be held on via Teams. It will still be broadcast on YouTube, but we will be online. And finally, I just want to thank Hertfordshire Community NHS Trust for lending us their facilities today, because we were having some problems in finding a room. So the technology we had to make it work was a little bit clunkier than normal, but we're very grateful and for their help with this. So thanks to them as well. Thank you very much. I'll draw this meeting to a close. Thank you.